in this session, we just today in this session we will be dealing with common GIT disorders. So, I'll wait for 2 minutes for so that everyone can join. Then we'll start. Just 1 minute. Let others too join. Okay, so we can start. So we'll be dealing with common GIT disorders today. So we know we are going to start the modern part of the Nidana, that is pathology, isn't it? So we know what is pathology. Pathology is nothing. See, if we talk about human body, it has a structure, that is the anatomical structure, isn't it? And it is working because of the systems in it, that is the physiological systems, isn't it? Whenever there is any kind of pathology involved, whenever any kind of pathology involved, either due to any pathogen or immune functioning disbalance or any other cause, then it leads to pathophysiology, isn't it? So we will be dealing with common GIT disorders. Now, what is GIT? We all of us know that it is gastrointestinal tract, isn't it? Gastrointestinal tract. So if we see, let's suppose that this is a person. So this is how. Okay, so this is the buccal cavity. Then we have this esophagus, then the stomach, obviously, and then duodenum, the jejunum ileum part. Then we have this colon part, then the rectum, obviously. Okay, so this is the complete GIT. Okay, so we will see first. I would like to give an introduction and a brief of what are the common disorders that are seen. Although we will be dealing with four of them, like we'll be dealing with ulcerative colitis, sorry, ulcerative dyspepsia, non-ulcerative dyspepsia, irritable bowel syndrome, and inflammatory bowel disease. Today we'll be discussing that. But what are the common GIT disorders and what are the possibilities? Let's see that, isn't it? We know this is the complete GI tract. Now, what can be the disorder? This structure over here, this buccal cavity, isn't it? What else can what can you expect? What disorders can you expect over here? Of course, we can expect oral ulcers, isn't it? So oral ulcers is a disorder that can happen. What else we can expect? We can expect carcinomas, isn't it, in buccal cavity and all. Okay, so these are the disorders that we can expect in the oral cavity of the GI tract. Another part is the esophageal part, isn't it? The esophagus. So if I talk about the esophagus, this part of the body, of the GI tract, then what is the thing? What disorders can we expect? We can expect eso eso esophagitis. Esophagitis. Okay, we can expect the inflammation of the esophagus, or we can also expect carcinomas, isn't it? Either infection, inflammation of the esophagus, or carcinoma can be expected. So this is the disorder. Now another part, if I talk about the stomach, this part of the body, the gastric part of the body, then what are the disorders that we expect? We can expect gastritis. We can expect gastroesophageal reflex disorders. We can expect peptic ulcers. We can expect ulcerative dyspepsia. We can expect other disorders too, isn't it? As well as carcinoma. So see the range of disorders that can come in this gastritis region. Now let's see the another part, that is the in small intestine part. Okay, so if I talk about the small intestine, so what all disorders we can expect over here? So here, this part basically, this can have which disorders? It can either have mostly malabsorption syndromes such as celiac disease, tropical sprue can be expected. Whose mic is on? Just a minute. Yeah. Okay, tropical sprue, then intestinal obstructions, as well as Crohn's disease. Okay, so these are the diseases or the range of disease we can expect in this intestinal region. We will see ulcerative colitis is there, Crohn's disease. All of this will be going today. We'll be seeing in detail. Okay, so this is there. Another part of GI tract, that is this part, large intestine. What all diseases do we expect to see over here? Let's see that. So the diseases, uh, please try not to do anything on the screen. Okay, so the diseases that we can expect in the this large intestine can be what? Either it can be ulcerative colitis, it can be diverticulitis, or it can be any other carcinoma in this section. Then if I talk about the anorectal part, here we go, this anorectal part, then what all diseases I can expect over here in GIT? I can expect hemorrhoids, fissures, fistulas, isn't it? Where as well as we know we have a beautiful organ over here which we call vestigial organ, that is the appendix. So what disease can we expect in this appendix? All of us know that is appendicitis. So appendicitis can be expected over here. Now, except this complete GIT tract, we know there are certain accessory organs, isn't it, involved over here? What are those? Those are kidneys, as well, liver, gallbladder, and pancreas. Okay, so these are the accessory organs over here, isn't it? So what are the diseases can we expect in these? Will also come under these GI tract accessories. So the liver, it will be having like it can hepatitis, cirrhosis, or carcinomas. If I talk about gallbladder, it can have cholelithiasis, cholecystitis, and carcinoma. If I talk about pancreas, it can have pancreatitis. So I hope that you have got a brief idea of this complete GI tract, isn't it? See, today we'll be dealing with four among these, although there are multiple disorders that can come, but we will be dealing with four of them. Okay, so I hope that this is clear, that these are the conditions that come in GI tract. So if we check each part of it, then each part have certain abnormalities, each part have certain disease. I will repeat for those who have came late, that is, we today will be dealing with common GIT disorders. For that, we are seeing the complete GI tract. We know it starts from the oral cavity to the rectal part, isn't it? So the oral cavity, it can have oral ulcers, carcinoma. The esophagus can have esophagitis or carcinoma. The gastric part, the stomach, can have gastritis, gastroesophageal reflex disorder, or peptic ulcer or carcinoma. If we talk about the small intestine, it have mostly the malabsorption disorders, the celiac diseases, the tropical sprue, intestinal obstructions, and Crohn's disease. Whereas if we talk about the large intestines, we have multiple disorders such as ulcerative colitis, diverticulitis, and etc., as well as cancers. If we talk about the anal rectal part, then what are the disorders? Hemorrhoids, fistula, fissures are the diseases. If we talk about the appendix, appendicitis can be there, as well as if we talk about the accessory organs, that is liver, gallbladder, and pancreas, then what will happen? Then it will have liver will have hepatitis, gallbladder will have cholelithiasis or cholecystitis, and pancreas will have pancreatitis. Okay, so now let's move on further and let's discuss what is ulcerative dyspepsia. I hope that everyone is following. Okay, so now let's go and let's see what is ulcerative dyspepsia. So basically, today we will be dealing with ulcerative and non-ulcerative dyspepsia. So before going into that, I would like to see what is dyspepsia first, isn't it? So what is dyspepsia? The term dyspepsia is made up of two words, we can say. One is this and another is pepsia. This means what? Anything which is impaired or bad. It's not good. It's not working properly. And pepsia, what is pepsia? Pepsia term means digestion. So ultimately, this word means what? There is bad digestion or the digestion have been impaired. Now what this bad digestion is going to do, now we know, see, we can correlate it with a day-to-day life. Whenever we have, when do we say that, oh, my digestion is not proper? Whenever we have discomfort or pain in upper abdomen, upper abdominal region, or we have early satiety, postprandial fullness, bloating, nausea, or belching. Like these are the conditions. Mostly, we should remember the six common conditions that will happen. So, what is dyspepsia? Dyspepsia is nothing but when the digestion is hampered and it causes what? Discomfort, pain, early satiety, postprandial fullness, bloating, nausea, and belching. Okay. So I hope that this term dyspepsia is clear. What is dyspepsia and what happens when dyspepsia happens? Now, this dyspepsia can be of two types. Dyspepsia can be of two types. What are these types? Either it can be ulcerative dyspepsia or it can be non-ulcerative dyspepsia. Okay, either it can be ulcerative dyspepsia or non-ulcerative dyspepsia. Now, what is ulcerative? Before digging into this thing, we have to know what is this term. This term ulcerative. What does this term mean? So let's see. So this term is made up of what? Ulcer plus ative. Now, ative is a suffix. Leave it. Now, if we talk about this term ulcer, what does this term ulcer means? It means that a localized defect is there. What is it? A localized defect or excavation of the surface of organ or tissue which produces what? Shed by the shedding of the inflamed necrotic tissue. I will explain. See, let's suppose that this is the lining of the GI tract. Okay, now beautifully the cells were happy over here, and oh, it doesn't looks to be happy. Okay, now okay, the cells were happily doing their work. So this was the normal pathway. Now what happened? Suddenly some inflammation came. Okay, so some inflammation came, and this cell has now it has now dead. So the cell has been dead, and after its death, now it will be shedded off. It will be shedded off. Once this cell gets shedded off, now what will happen? Once it gets shedded off, there will be a gap left, isn't it? So let's suppose that it got shedded off, and this over here, let's suppose a gap was created when it went. So this particular place is now an ulcer. This is an ulcer. Okay, I hope that this is clear. What is ulcer? So ulcer is a localized defect or excavation of the surface of organ or any tissue which is produced by shedding of what? The inflamed necrotic tissue. Okay, I hope that this is clear what is ulcer. So now let's see what is ulcerative dyspepsia. And then later on we'll be seeing what is non-ulcerative dyspepsia. So what is ulcerative dyspepsia? I hope both of these terms are very well clear, that what is ulcerative and what is dyspepsia. So something where there will be ulcer and that is going to have what? Bad digestion. Then this is what ulcerative dyspepsia is all about. Now one thing is clear very well by this term itself. What? that it is a structural defect. There will be definitely there will be structural lesion involved, isn't it? So structural lesion is involved in ulcerative dyspepsia. Now let's see what are the common causes and what is will in short we'll be seeing the pathophysio, okay, in very short, and then we'll move on. Basically we will try to learn ulcerative dyspepsia in such a way that if question comes for 5 marks, what we can write. Okay, so let's suppose ulcerative so ulcerative dyspepsia, what are the causes? What are the causes? So let's suppose any acid, any acid, or your stomach acid itself, okay, or H pylori, Helicobacter pylori, or any painkiller, non-steroidal anti-inflammatory drugs. When a person is taking all of these, or when this is in excessive, so these are basically the aggressive factors. Aggressive factors. What it is going to do? It is going to overpower the mucosal defenses. We know that the mucosal layer is trying to defense, isn't it? It is protecting the other structures beneath it. Now when these things are in excess, what happens? When these are in excess, what happens? This is going to overpower the mucosal defense. If it happens in each of the condition, let's see what happens in a short detail. Now let's suppose that when the acid or the pepsin is higher, then what will happen? It will definitely attack the weakened mucus layer, and it will cause ulcer. So if the acid secretion increases due to any reason, either you are taking too much of alkaline food, or even because of any reason, if the acid increases, what will happen? It will attack it will attack the weakened mucosa, okay, and then what it will cause? It will cause ulcer. Now what if H pylori comes, isn't it? It's an infection, it's a bacteria. What if this bacteria enters in the body? Now this H pylori, what it does, it has two functions. Now the first thing, it decreases the somatostatin. It decreases the somatostatin. Now we know if the somatostatin is decreased, what will happen? The gastrin will increase. The gastrin will increase. And once the gastrin has increased, what will happen? The HCl will increase. Let me clear. Somatostatin does what? It will inhibit the acid secretion in the stomach. Whereas gastrin does what? It increases the acid secretion in the stomach. So this stomatin is always controlling the gastrin. Okay. So what this H pylori is doing? It is decreasing the somatostatin, because of which what is happening? The gastrin increases. Once the gastrin will increase, what will happen? HCl will increase. Now this factor can come here, that the acid has increased. So once the acid has increased, what it will do? It will attack the weak mucosa layer, and then ulcers will form. Okay, now the another thing that this H. pylori does is secretes an enzyme that is urease. Now we know what this urease can do. What this urease can do? It will break the urea, isn't it? It will break the urea. Urease is going to break the urea. When urease will break the urea, what will happen? So when urease break the urea, there will be secretion of ammonia and CO2. Okay, now this ammonia, what it does? Now this ammonia again damages the epithelial cells, and it stimulates acid secretion. Again it will increase the acid secretion, attack the mucosa, and then ulcer will be formed. Okay, I hope that this part is clear what this H pylori is doing over here. Okay, so this thing is there. Now we know this no, if someone is confused that how this ammonia is increasing the acid, so I hope that you might be knowing that ammonia is going to increase the pH, and we know nature of the nature is to have a balance, to have an equilibrium. Similarly, in our body, our body always try to maintain the equilibrium. So once the pH will increase, what will happen? The stomach will start secreting the LCL in order to take it back to the equilibrium, so that the equilibrium is maintained. And because of that, what will happen? HCl will increase, acid will increase, and this acid will again cause harm. If it is in excess, it is going to cause harm to the mucosal layer, and definitely ulcer will be formed. Okay, now the third factor that we discuss that can cause this ulcerative dyspepsia is what? It is non-steroidal anti-inflammatory drugs. Now, these non-steroidal anti-inflammatory drugs does what? We know pain, how they reduce the pain? By reducing the prostaglandins. By reducing the prostaglandins, we feel pain because of these prostaglandins. So this and non-steroidal anti-inflammatory drugs, they come as, they are the painkillers, so they'll be reducing the PGs, the prostaglandins. And then what will happen? These prostaglandins does what? They reduces the bicarbonates and mucosa, and because of which the mucosa becomes very weak. So they reduces the secretion of the mucosa, because of which the mucosal layer becomes very weak. And once it becomes weak, what happens? Definitely there are chances of shedding off and ulcer formation. So I hope that this thing is clear, that how this ulcerative dyspepsia is happening. So we discussed what? Three factors: either acid secretion is high, either H. pylori bacteria, or the non-steroidal anti-inflammatory drugs are there. So what are these going to do? Either they will affect the mucosa, either they will increase the acid, either it will decrease the PGs, either they will decrease the somatostatin, increase the gastrin. Ultimately, what they are doing, they are harming the mucosal layer, they are harming the epithelial cells. And because of this harm, what is happening? The epithelial cells get shedded off and create a space over there, and that is what we call ulcer. So I hope that it's clear what is ulcerative dyspepsia. Okay, now what will happen when this ulcer will be created? Then what is the problem? Let it create, isn't it? We might be thinking that, but there is issue. What are these issue? Let's see. Okay, so this will definitely cause indigestion, isn't it? So ulcerative dyspepsia is of two types. What are these types? Either it can be gastric ulcer, or there can be duodenal ulcer. Why only gastric or duodenal? Because we know this acid secretion, and acid secretion is mainly where? In the gastric part, and somewhat goes into the duodenal part also. Okay, so this is there. Now the typical thing that will help you to create a difference or to understand whether your patient is having gastric ulcer or duodenal ulcer, and that is the type of pain. Let's suppose your patient comes with an abdominal pain. Okay, your patient comes with abdominal pain, and he says that whenever I am taking my meal, my pain gets aggravated. Okay, what your patient said? Whenever I am taking the meal, my pain is getting aggravated. Okay, then you thought, okay, why it is happening? Oh, maybe because the food is enter when the food enters, what happens? The acid secretion increase, the gastrin, the stomach starts working, the stomach sends the signal, oh gastrin, come on, secrete the HCl. So when the HCl increases, what happens? It definitely causes the pain, because there is already ulcer is there, and it is aggravating it. Okay, so it happens. So when does it happens? Where the HCl secretion will be more? Definitely in the gastric ulcer. So if your patient is saying that the patient is having pain, or pain gets aggravated after meal, then it is definitely gastric ulcer. Okay, whereas another patient came and your patient said that, oh doctor, I'm getting pain of my pain is relieved when I take food, but when I'm empty stomach, it's too much of pain is there. Then what we have to think? We have to think of duodenal ulcer. Why it is happening so? Because when food enters the stomach, what happens? The gastric acid is initially buffered by the food. Let's suppose that HCl, a quantity of HCl was present. Now the food came. Okay, now some buffer is there. Okay, so what happens? The HCl reduces for a while, and HCl reduces for a while in the duodenal region, because this HCl is will be now busy in, first of all, buffering the food which has came. So the transfer of this HCl to the duodenum will be decreased. So once it is decreased, what will happen? The patient will feel mild relief while taking the food. So if your patient says that I am having pain after taking meal, it is definitely gastric ulcer. Okay, it is definitely gastric ulcer, it happens there. But if your patient says I get relieved by taking the food, then it is duodenal ulcer. I hope that it is clear. So this was one of the clinical feature of what? Of ulcerative dyspepsia. Okay, now let's move on to another clinical feature. What is that? So another one is definitely bloating will be there, isn't it? Bloating will be there. Why bloating will be there? Let's suppose that your patient is having ulcerative dyspepsia due to what? Due to H. pylori. Then definitely we knew what H. pylori was doing. It was secreting an enzyme urease. What that urease was doing? It was breaking the urea into ammonia and CO2. CO2. Okay, so definitely bloating and all will be there. Not necessarily in H. pylori only. It can be there in other ulcerative dyspepsia because of other causes too. Okay, another nausea can be seen. Nausea can be seen, or in some of the patients, rarely, there can be hematemesis. Hematemesis, that is vomiting of blood. Okay, now there so this is all about ulcerative dyspepsia. Ulcerative dyspepsia. Okay, now we'll talk about diagnosis, like, because this is an interesting part, how we are going to do diagnosis of this part. So diagnosis, like epigastric tenderness can be seen. Sorry, clinical examination, epigastric tenderness can be seen. The patient might have anemia, so we can go for CBC and all of that. And in diagnosis, definitely in the lab investigation, we go for endoscopic demonstration. If the mucosal layer is more than 0.5 centimeter inflamed, then definitely we think of ulcerative dyspepsia. And we also do H. pylori test. If it is positive, then it is ulcerative dyspepsia. I hope that ulcerative dyspepsia is clear to all. So now let's move on to non-ulcerative dyspepsia. Non-ulcerative dyspepsia. Now, we knew very well, when we started, what we discussed, what is dyspepsia? Nothing. Bad digestion is dyspepsia. Then what is ulcerative dyspepsia? When ulcer will be there. Now the term itself is telling you here there won't be any ulcer. So what does that mean? Here there won't be any structural involvement. Okay. So what it is a functional effect. Okay. So without any ulcer or structural disease, then it is non-ulcerative dyspepsia. So what is it? It is basically chronic or recurrent dyspeptic symptoms without any ulcer or structural disease. Okay, so this is non-ulcerative dyspepsia. Now the causes can be like, actually the thing is that yet we don't know the cause of this non-ulcerative dyspepsia, but it is said it can be multifactorial, or it can be any of the factor, one or two factor, or maybe multiple factors can be there. Okay, so what are they? It can be either H. pylori. Again, this culprit H. pylori is there. Then abnormal motility of the stomach, or there can be psychological effects, stress and all, or diet patterns. We know ahara and vihara, all of that will come over here, or any drugs, non-steroidal anti-inflammatory drugs and all. Okay, now what will happen because of all of these causes, either H. pylori or abnormal motility or psychological or visceral hypersensitivity or diet patterns or non-steroidal anti-inflammatory drugs? What these are going to do, this will have different pathophysios. So let's see what are they. Either it will impair the gastric accommodation. Now what is impairing of the gastric accommodation? We know, see, we know this thing. This is our stomach, right? This is a stomach. So here, this part, the fundus part of the stomach. What happens? The fundus fails to relax. what will happen? The fundus will fail to relax. If the fundus fails to relax, then what will happen? The space will reduce. So less accommodation can be done, you can't take more food. So what will happen? You will be having early satiety. Okay, you'll be having early satiety. So first thing is what? It will impair the gastric accommodation. How? By failing the fundus will fail to relax because of that. The another thing that is possible is the delayed gastric emptying. If there is delayed gastric emptying, yeah, when your gastric region is not getting empty, definitely you will be having bloating, or there will be postprandial distress. These things will be seen. Another reason, second one is delayed gastric emptying. Okay, the third is visceral hypersensitivity. Now what is visceral hypersensitivity? Now let's suppose this also causes pain. Like, I'll be explaining this visceral hypersensitivity in detail when we will be discussing IBS. Okay, because there more of this sensitivity is seen, because over here in non-ulcerative dyspepsia there is pain. When we'll talk about the clinical features, we get to know that epigastric pain is there, burning sensation is there, early satiety and all this thing is there, whereas the bowel thing is seen very less. Okay, so visceral hypersensitivity. See, for these, like in modern science, most of the things are not clear. The pathophysios, they are assuming that this may be the thing, and the factors also, they don't know whether it is the factor or not. So they are saying that visceral hypersensitivity can be a cause of this thing. Okay, the fourth one, H. pylori. We will discuss visceral hypersensitivity in detail. Don't worry. So H. pylori. H. pylori is related to low grade inflammation. Let's suppose if there is low grade inflammation of H. pylori, then also it can cause what? Non-ulcerative dyspepsia. Or when your gut brain axis is affected due to stress or anxiety or anything. Okay, so these are the pathophysio. What are the causes? Multiple causes, multifactorial causes. What are the pathophysios? Either the gastric accommodation is affected, either the the stomach part is not getting empty, it is getting delayed, or visceral hypersensitivity, or H. pylori, or the gut brain axis is getting affected. Okay, so this is all about non-ulcerative dyspepsia. Now let's see the clinical features of non-ulcerative dyspepsia. What are the clinical features? There will. क्या हुआ? Oh, just. Okay, so yeah, we were discussing about clinical features. Clinical features. Clinical features. So there can be epigastric pain. Epigastric pain. Epigastric pain will be there, or burning sensation will be there, or postprandial fullness will be there, or early satiety will be there. We have discussed the reason why it will be there. And nausea, blotting, belching will be there. Okay, so these are the clinical features. Now what are the clinical examinations? What can be there? It we can, like, mostly it's normal, like when the person will come, and if you do the clinical examination, you'll feel like, oh, nothing much is there, but there can be mild epigastric tenderness. Okay, so this is the thing. Now what is the diagnostic criteria? So in diagnostic criteria, we have rome 4 diagnostic criteria. Rome 4 diagnostic criteria for this thing. Okay, now what is it? It is nothing but four things come under it. What are those four things? Postprandial fullness. Okay, postprandial fullness. Then early satiety. Then epigastric pain. Then what? Epigastric burning. So Rome 4 is nothing but P triple E. P. This is Rome 4. Okay, Rome 4 was roaming and doing and peeing. So you can remember it like that: P triple E P. What is postprandial fullness, early satiety, epigastric pain, and epigastric burning sensation will be there. So this is Rome 4. So definitely there will be no evidence of structural diseases, but if this thing is seen, this postprandial distress syndrome is seen at least 3 days per week, if it is seen at least 3 days per week, and if this epigastric pain and this thing, if it is seen 1 day per week, then we can think of what, this non-ulcerative dyspepsia. I hope that ulcerative dyspepsia and non ulcerative dyspepsia is clear to all of you. I'll just give a short review of what we discussed. We discussed about the common GIT disorders, in which we saw the complete GI tract and the possibilities of the disorders in all of the part of the GI tract. In that, we studied about the dyspepsia. What is dyspepsia? Nothing but bad digestion. Okay, so bad digestion. It can be either ulcerative or non ulcerative. When it is ulcerative, structural involvement is there. When it is non ulcerative, there is no involvement of the structure. Then we saw what factors were in ulcerative were acid, acid pylori, non-steroidal anti-inflammatory drugs, which were causing what? It will either cause pain, or there was what, a bloating, nausea, hemat emesis, etc. was there. The typical one was what? Gastric ulcer and duodenal ulcer. Gastric ulcer aggravates, the pain will aggravate by meal. In duodenal ulcer, the pain will be relieved by the meal. Okay. Whereas then we discussed about the non-ulcerative dyspepsia. No structural